respected seniors, teachers, faculty members, and delegates. Greetings from IAP Neocon 2021. I am Dr. Rajagopalan, Coordinator, IAP Neocon 2021. Let us start the 21st webinar of Learn from the Legends, International Bi-monthly Webinar Series, an academic initiative of IAP NeoChap, which is organized by National Neonatology Forum, Kerala, and Indian Academy of Pediatrics, Thrissur branch. We have nearly 4,000 registrations from 75 countries for this scientific feast. A warm welcome to all delegates in Zoom platform as well as YouTube channel on behalf of IAP NeoChap for today's program. Today, we have an eminent faculty, Professor Dr. Zubair Aghai from Thomas Jefferson University, Philadelphia, USA, to address an important topic, umbilical cord management in non-vigorous neonates, updates and future. We welcome you, sir, for today's webinar. Two senior experts in neonatology of our country are moderators for today's session, Dr. Mohit Sahani from Surat and Dr. Amit Upadhyaya from Meerut. Hearty welcome to both of you to the webinar. Now, I request moderators to take over the proceedings. Over to moderators.
Hello. Good evening, everyone, and good morning, Professor Zubair. We are lucky that we are being a part of this. I know there are a lot of issues, online things are happening, but NNF Kerala, Dr. Manoj and team have done a wonderful work for this Learn from the Legend series. And today's topic, umbilical cord management in non-vigorous newborn, from the legend itself, Dr. Zubair. So there, we know it's guidelines for the normal babies and everything to clamp the cord at 60 seconds is the norm. But for the non-vigorous babies, every time we used to hear, what to do because there were no clear-cut guidelines. Either we should have very modified, specialized trolleys, which are very costly, lifestyle or something like that, to have by the mother side to do that. But what is being now updated things regarding that, it will be nice, and I am really excited to hear from the horse's own mouth. So I would like Dr. Amit Upadhyay to please introduce Professor Zubair. Thank you very much.
Hello, thank you. Dr. Zubair has been a great academician and a clinician. Dr. Zubair H. Aghai had done his MBBS from India. So I would begin with that itself, that Dr. Aghai had done his MBBS and MD Pediatrics from Nagpur Government Medical College. And so he is a proud Indian. Since then, he did his American Academy of Pediatrics qualification, followed by fellowship in neonatology, neonatal perinatal medicine. And I'm so happy to read that he stood third among almost 3,000 candidates who appeared for this exam. So he's an excellent academician. After that, he has joined Sydney Kimmel Medical School at Thomas Jefferson University in Philadelphia, USA. He's a program director there, and he's director of neonatology research. And he has more than 75 peer-reviewed publications. He has more than 200 international conference presentations, and he has had the Lung Association, Gerber Foundation, NIH, and his areas of research include neonatal sepsis, HIE, umbilical cord management, on which he will deliver his talk today, on non-invasive ventilation, epigenetic and chorioamnitis, and biomarkers for BPD. And so with this introduction, back to you, Dr. Mohit, to please introduce the topic.
Yeah, thank you, Dr. Amit. So now everyone knows now that the topic is this is what to do with the umbilical cord if there is non-vigorous babies. So I would request and welcome Dr. Professor Zubair to kindly start his presentation, please.
Yeah, thank you, Dr. Amit and Dr. Mohit for a kind introduction. And thank you, Dr. Manoj and NNF Kerala for inviting me for this talk. It's a real pleasure and honor to be talking on this forum. And I will also like to thank the audience for choosing to join my talk on this Saturday night instead of having fun. So I'll start with my talk. I have nothing to disclose except I will be using data from several papers by Anup Katheria. He has done pioneering research in umbilical cord management in a newborn baby. And I will also be using a few illustrations prepared by Satyan. We all know Satyan is a great neonatologist, great teacher, and a researcher, but he's also an excellent illustrator. And so I'll be using some of his pictures in my talk. Let me just start with some simple questions. You can answer this on Google poll. You have a term baby who's vigorous at birth. Baby is crying, baby is breathing, has a normal tone. How long do you wait before clamping the cord? Will you do immediate cord clamping, or you will wait for 30 to 60 seconds, 1 to 3 minutes, and more than 30 minutes before you clamp the cord, or you will perform umbilical cord milking? Let's start the answers. We'll give about 25 to 30 seconds for you to answer this question. Okay, I'm really happy that most of you will do a delayed cord clamping on this baby. Let's do a second baby who's a preterm baby. Similarly, baby is a vigorous at birth. Baby is crying, breathing, and in normal tone. How long do you wait before you clamp the baby? And again, we will do the poll and wait for 25 to 30 seconds. Yeah, thank you again for answering these questions. If your answer for both preterm and term baby who are vigorous at birth, you will wait for clamping the cord for 1 to 3 minutes. Probably you're right, because that's what is recommended by WHO. But if your answer is 30 to 60 seconds, that's correct too, because ACOG, the AAP, and NRP recommend delayed cord clamping for 30 to 60 seconds. The umbilical cord milking is not currently recommended for premature babies or term babies who are vigorous at birth. This is my next question. Where do you place the baby while performing umbilical cord delayed cord clamping? At or below the level of placenta, or over mother's abdomen or chest? Yeah, thank you again for answering that questions. Most of you will place the baby over mother's abdomen or chest. Both answers are correct, but if you are keeping the baby over mother's abdomen or chest, 30 to 60 seconds of delayed cord clamping may not be sufficient, and I will explain this in my talk. Let's go to the next question. Now you have a term baby who's depressed at birth. Baby is not breathing, not crying. Baby is hypotonic and pale. How will you manage the cord clamping on this baby? Will you do an immediate cord clamping, or you will wait for 30 to 60 seconds or 1 to 3 minutes before clamping the cord? Or will you start bag and mask ventilation and clamp the cord after 1 minute? Or you will perform umbilical cord milking? Again, you have 25, 30 seconds to answer these questions. And thank you again for participating in these questions. That's really give information how you are managing this baby. So most of you will do immediate cord clamping. Some of you do bag and mask ventilation. I saw a few of them will perform umbilical cord milking. What about in preterm baby who was depressed at birth? Baby is not crying, not breathing, hypotonic. How will you manage the cord on this baby? Will you do an immediate cord clamping or wait for 30 to 60 seconds, 1 to 3 minutes, or use a bag and mask ventilation or perform umbilical cord milking? Okay, thank you again for answering that question. Again, most of you will do immediate cord clamping. Some of you will do a bag and mask ventilation. Few will do umbilical cord milking. So the babies who are depressed at birth, the current recommendation by WHO, ACOG, NRP is an immediate cord clamping. But helping baby breathe recommends, if possible, you can do a bag and mask ventilation and cord clamping after 1 minute. Performing umbilical cord milking is a good idea, but currently it's not recommended in vigorous or non-vigorous both babies. So at least till we get more information, more data, we should not be performing umbilical cord milking except in a clinical trial. So placental transfusion with a delayed cord clamping is a no-cost, low-tech intervention that can have huge impact on both short and long-term outcomes in preterm and term infant. But despite a strong recommendation from 35 organizations, clinicians are still reluctant to adopt delayed cord clamping. And I was happy to see the poll that most of you, you are doing a delayed cord clamping in preterm and full-term babies. So these are the goals for my talk today. I will briefly talk about delayed or deferred cord clamping and umbilical cord milking in a vigorous infant. Then I will compare umbilical cord milking and delayed cord clamping. And then I will talk in detail about options for placental transfusion in non-vigorous infants. So at birth in term baby, 67% of blood volume is in baby, and 33% is in placenta. In preterm baby, 50% of blood volume is in baby and 50% is in placenta. Placental transfusion is a transfer of placental blood to the baby during the first few minutes after birth. And this can be achieved either by a delayed cord clamping or umbilical cord milking, which can be an intact cord milking or cut cord milking. At birth, spontaneous respiration and opening of the lung leads to pooling of substantial volume of blood into the lung, and the babies are relatively hypovolemic immediately after birth. So placental transfusion increases the infant's blood volume and perfusion to important organs and help in transition from fetal to neonatal circulation with minimal alteration in cerebral blood flow. Placental transfusion also supply extra immunoglobulin that may reduce infection, supplies extra red cells that may reduce blood transfusion and improve iron store. Fetal blood is also a rich source of stem cells that may help in organ repair, especially in premature baby and infant with HIE. In delayed cord clamping, the cord is left unclaimed for a short period of time after birth, and the blood from placenta passes to infant. ACOG, NRP, AP, and WHO, and other 35 organizations recommends delayed cord clamping for 30 seconds to 3 minutes in vigorous preterm and term neonates. With delayed cord clamping, approximately 25 ml of blood is a transfer from placenta to baby. More blood is transferred with vaginal delivery than by C-section, and I will explain this in my next slide prepared by Satyan. So there are 4 important factors that determine transfer of blood from placenta to baby: uterine contraction, gravity, negative intrathoracic pressure generated by spontaneous respiration, and timing of cord clamping. With each uterine contraction, placenta is squeezed and the blood from placenta goes to the baby. So if the babies are born by the uterine there is no uterine contraction or ineffective uterine contraction. So the baby is born by C-section, they receive less blood from placenta. If you place the baby at or below the level of placenta, the gravity facilitated a transfer of blood from placenta to baby. But if you are putting a baby on abdomen and chest, as I said before, you're not getting a benefit of gravity. And the benefit of gravity is controversial, but probably 30 to 60 seconds of delayed cord clamping may not be effective on this baby. So babies who are depressed at birth or who are not crying, there's no negative thoracic pressure. The negative thoracic pressure with a spontaneous respiration pulls the blood from placenta to the baby. So if the baby is not breathing or you cut the cord before baby starts breathing, then there is a decreased transfer of blood from placenta to baby. And the timing of the cord, the longer you keep the cord intact, there's a more transfer of blood. Most of the blood is transferred from placenta to baby in 1 to 3 minutes. So this is the benefit of delayed cord clamping in preterm babies. This is a meta-analysis from 18 randomized clinical trial, and that shows 32% decrease in mortality in preterm babies with delayed cord clamping compared to early cord clamping. If you compare 2 other therapy that has a huge impact on mortality in preterm baby, antenatal steroid and surfactant for RDS. Antenatal steroid decreases mortality by 31%, and surfactant reduces mortality by 10 to 40%. So reduction in mortality by delayed cord clamping is similar to the use of antenatal steroid in premature baby and may be a better than use of surfactant in preterm babies. These are some other benefits of delayed cord clamping in preterm babies compared to immediate cord clamping. Delayed cord clamping decreases the need for inotropes for hypotension. It decreases the need for blood transfusion and decreases any IVH in premature baby. There is also trends towards lower PVL, late onset sepsis, and treatment for ROP with a delayed cord clamping in premature baby. But there is a trend towards higher treatment for PDA with delayed cord clamping in premature babies. Delayed cord clamping in premature baby also improves iron stores at 4 months and neurodevelopmental outcomes at 2 years in preterm babies. These are the benefits of delayed cord clamping in term babies. In term babies, delayed cord clamping improves hemoglobin and iron stores. And a meta-analysis from 5 randomized controlled trials shows that delayed cord clamping in full-term baby reduces risk for iron deficiency at 3 and 6 months of age. As you all know, iron deficiency is common during early infancy. We recently reported that 20% of neonates admitted to the NICU have low MCV, suggestive of iron deficiency. We have been taught that fetus is a perfect parasite. Even if mother is iron deficient, the newborn babies are not iron deficient. This may not be true. This is a study from China. We showed 45% of infants born to mothers with iron deficiency were iron deficient at birth. And iron deficiency is very common during pregnancy. 40 to 80% of pregnant mothers have iron deficiency. As you all know, iron is very important during the critical period of brain development, and iron deficiency at birth or during early infancy is associated with long-term neurodevelopmental impairment. Delayed cord clamping also increases myelin content at 4 months of age in brain region associated with motor, sensory, and visual processing and function in term babies. Delayed cord clamping improves neurodevelopmental outcomes at 4 years of age in full-term babies. This is an unexpected benefit of placental transfusion or delayed cord clamping. This is a study from Kenya. Anemia and iron deficiency at time of vaccination decrease response to diphtheria, pertussis, and pneumococcal vaccine, and iron supplementation increase humoral vaccine response. Placental transfusion can increase vaccination response by preventing iron deficiency in this critical period. Delayed cord clamping is also associated with increased risk of polycythemia, but there was no difference in symptomatic polycythemia in term babies. Delayed cord clamping also increases jaundice, but in term baby, the risk of phototherapy was increased by only 2%. And in preterm babies, there was increase in peak bilirubin level, but no significant increase in use of phototherapy. As you know, delayed cord clamping may jeopardize timely resuscitation. That's why it's not recommended by most of the organization in babies who are depressed at birth. But placenta continue to perform gas exchange, and ventilation with intact cord is one of the options in babies who are depressed at birth. This term, going to the last mile, comes from telecommunication and cable industry. It's very easy to take the cable or phone line to a city, but the hardest part is distributing it to each and every household. The same problem is with the delayed cord clamping and going to the last mile. Despite strong recommendations from 35 organizations and proven benefit, delayed cord clamping is not routinely performed in neonates. In California, 42% of preterm babies admitted to the NICU did not receive delayed cord clamping. And in Canada, 40% of preterm infants admitted to an ICU did not receive delayed cord clamping. In China, only 30% of hospitals included delayed cord clamping in early newborn care practice. I'm sure there's the same problem in India. So we have to go to that last mile. We need to convince our OB colleagues that delayed cord clamping is really important and should be performed in every baby who's vigorous at birth. Delayed cord clamping or placental transfusion is the easiest and cheapest way of decreasing mortality in premature babies and improving few IQ points in all babies. Improving few IQ points makes a big difference in everybody's life. I wish Donald Trump had a delayed cord clamping, but I'm not sure improving few IQ points to him would have made any difference. Now I'm switching to umbilical cord milking. Umbilical cord milking is a milking of umbilical cord 2 to 5 times towards baby immediately after birth. It provides similar blood transfer as 2 minutes of delayed cord clamping. These are the differences between delayed cord clamping and umbilical cord milking. In delayed cord clamping, there is a passive transfer of blood. It is a gravity dependent. It's a time sensitive, and it's dependent on mode of delivery. There is a decreased transfer of blood in a baby is born by C-section. It also depends on the spontaneous breathing. In a baby who are not breathing, there is a decreased transfer of blood when you're doing a delayed cord clamping. Compared to that, umbilical cord milking, there is an active transfer of blood, is independent of gravity. There is a minimal delay, so we can do it in babies who are depressed at birth. It is independent of delivery, so you can have a good amount of blood transfusion in a babies who are born by C-section. It's not affected by spontaneous breathing, so you can do umbilical cord milking in a babies who are depressed at birth. And probably there is a more transfer of stem cells with umbilical cord milking, because milking of the umbilical cord strips some mesenchyme stem cells from the endothelium. Those stem cells are gone to the babies. So what are the advantages of umbilical cord milking? Umbilical cord milking can be done in a babies who are depressed at birth and need immediate resuscitation. It may also assist with earlier onset of breathing. In an older study, more infant breathed before cord clamping with umbilical cord milking compared to delayed cord clamping. And as I said before, the blood transfer after umbilical cord milking probably contains more mesenchymal stem cells. And this is milking is a more efficient way of transferring blood from baby, from placenta to the baby in infant born by C-section. And in one of our study from Anup, the neurodevelopment outcome was better at 24 months with the umbilical cord milking compared to delayed cord clamping in preterm babies. So umbilical cord milking can be done with intact cord milking, where the cord is connected to placenta and you milk cord after a refill 2 to 4 times towards baby, it takes less than 15 to 20 seconds. And probably there is a greater volume of placental transfusion with milking with the intact cord because the cord is refilling with after each milking. The cut umbilical cord milking is when a long segment of umbilical cord around 20 to 30 centimeter is cut immediately after birth. And then the neonatologist or the pediatric provider untwist and milk entire content of the cord into the baby, but there is no refilling because the cord is already cut. But this can be performed while we are resuscitating baby. And a small study from Japan has shown there is a similar amount of blood transfer with cut umbilical cord milking compared to intact cord milking. However, cutting the cord before the onset of respiration can have adverse consequences, which I will explain in later slide. So comparing umbilical cord milking with the immediate cord clamping in preterm babies, again, the umbilical cord milking reduces the need for blood transfusion in premature baby, but there was no difference in mortality. There was a trend towards decreased IVH, decreased severe IVH, decreased necrotizing enterocolitis, and decreased treatment for ROP with umbilical cord milking compared to immediate cord clamping in preterm babies. This is a comparison between umbilical cord milking with a delayed cord clamping in preterm babies. There was no significant difference in mortality with umbilical cord milking compared to delayed cord clamping in preterm babies. And there was no significant difference in any IVH in a babies who received umbilical cord milking versus delayed cord clamping. But this is concerning. Umbilical cord milking was associated with increased severe IVH compared to delayed cord clamping in preterm babies. This increase was almost twofold with umbilical cord milking in premature baby. And this result is driven by this large study, Anup, who published this in JAMA last year on association of umbilical cord milking with a delayed cord clamping. And the primary outcome was death or severe intraventricular hemorrhage. There was no significant difference in primary outcome of death or severe intraventricular hemorrhage in a baby who received umbilical cord milking versus a delayed cord clamping. But this study was stopped in between by DSMB because a subgroup of infants born between 23 weeks and 27 weeks of gestation, there was a significant increase in severe IVH with umbilical cord milking. About 22% of infants who received umbilical cord milking in this subgroup had a severe IVH compared to only 6% baby who received a delayed cord clamping. But they did not see any difference in severe intraventricular hemorrhage in a larger babies born between 28 and 31 weeks of gestation. In fact, none of the 143 babies born between 28 and 31 weeks of gestation who received umbilical cord milking had a severe intraventricular hemorrhage. So the DSMB, after reviewing this, they permitted to continue this study on a bigger baby. And I am excited to see the long-term effect of umbilical cord milking on these premature babies. So benefit of umbilical cord milking in term baby. So this is a studies. These are the 5 randomized controlled trial compare umbilical cord milking with immediate cord clamping in term babies. And 3 of this trial was performed by our moderator, Amit and his team. So umbilical cord milking compared to immediate cord clamping improve blood pressure, hemoglobin within the first few days of life, and iron store at 6 weeks But the most important, umbilical cord milking was not associated with any harm in this 5 randomized control trial. This is a meta-analysis on comparing umbilical cord milking with a delayed cord clamping in term babies. So the hemoglobin level at birth at 48 hours and the serum bilirubin at 48 hours were similar in umbilical cord milking group versus delayed cord clamping group, suggesting both umbilical cord milking and delayed cord clamping have similar placental transfusion in a full-term babies. There was a higher hematocrit hemoglobin level at 6 weeks with the umbilical cord milking. So maybe the umbilical cord milking is more efficient way of placental transfusion. I think many of these babies were born by C-section, so that's why they're showing a better placental transfusion. Now I'm switching my gear and I will talk about placental transfusion in a non-vigorous infants. We all know the infant who are depressed at birth, they require resuscitation, and these infants are at increased risk for HIE. 5 to 7% of all infants require resuscitation at birth. An improvement in the delivery room management could improve long-term outcome. We have shown that about 25% of infants who are depressed at birth develop moderate to severe HIE. And we all know that HIE is one of the leading causes of neonatal mortality, not only in India, all over the world, and 20% of neonatal death being directly linked to HIE. The incidence of HIE is 1 to 3 per 1,000 birth in high-income countries, and it is 15 to 20 times greater in low and middle-income countries. The only effective therapy for HIE is a therapeutic hypothermia. But even after therapeutic hypothermia, 50% of infants with moderate to severe HIE either die or develop moderate to severe neurological deficit. The therapeutic hypothermia is not available in and therapeutic hypothermia does not reduce neonatal mortality in low and middle income countries. I'm sure you all aware of well-designed HELIX trial on therapeutic hypothermia for HIE in low and middle income countries. The results of this study is not published yet, so I don't know how much results we can discuss now, but Dr. Thayil, he presented some of the data in Hot Topics in Neonatology last month. And I can say that the results of this trial is disappointing. So we emergently need some neuroprotective strategies for HIE. And these are some of the intervention and therapy undergoing clinical trial at this time. And 2 of them is a umbilical cord, stem cell transplant, and placental transfusion. Umbilical cord blood is a rich source of stem cells. In animal models of HIE, umbilical cord blood mononuclear cell transplantation showed improved neurological outcomes. There are 2 recently published pilot studies on safety and feasibility of autologous cord blood cells for infants with HIE. In our lab, we estimated the number of mononuclear sites a term neonate receive after umbilical cord milking or delayed cord clamping. And this number is similar to those used by those pilot study. So probably the umbilical cord milking or delayed cord clamping or placental transfusion is same as autologous cord blood cell transplantation. So the neonates who are depressed at birth, they are likely to benefit most from placental transfusion. We all know the neonates who are depressed at birth, they are hypovolemic, and placental transfusion can improve that hypovolemia and increase perfusion to brain. The cord blood also provides stem cells and growth factor. Sandberg rightly described delayed cord clamping as a nature's first stem cell transplant. Placental transfusion also prevent iron deficiency and may improve neurodevelopmental outcome. But currently, most of the organization do not recommend delayed cord clamping in babies who are depressed at birth, except helping baby breathe. They recommend ventilation with intact cord. So there are two options for placental transfusion in a depressed neonate: umbilical cord milking and ventilation with intact cord. The umbilical cord milking can be intact cord milking or cut cord milking. So umbilical cord milking does not interfere with resuscitation, so can be used in babies who are depressed at birth. This is a simple technique, does not require extensive training or additional staff. And most of the infants who are depressed at birth, they are born by C-section. And we know there is a more efficient transfer of blood with umbilical cord milking compared to delayed cord clamping in a baby born by C-section. And probably there are more stem cells with umbilical cord milking because of the stripping of the umbilical cord and release of the mesenchymal cells from the endothelium. But there is a concern for increased blood flow to the brain with umbilical cord milking, especially if the baby is not breathing and the lungs are not open. So all the blood we are pushing to the baby is going into the systemic circulation. And especially this is concerning for premature babies. And we have a very premature baby, umbilical cord milking can cause intraventricular hemorrhage. This is again Satyan's picture. The babies who are depressed at birth, they have low left ventricular preload because of the loss of fetal or neonatal blood from nuchal cord or placental abruption, decrease venous return because of lack of negative intrathoracic pressure, that the baby is not breathing or has a poor respiratory effort, or decrease return of blood from unventilated lung. All those contributes into a low left ventricular preload. Umbilical cord milking restore this left ventricular preload and improve pulmonary and cerebral blood flow. Umbilical cord milking can also stimulate respiration. So ours was the first study published on umbilical cord milking for neonates who are depressed at birth. This was a randomized trial of safety and feasibility was performed in Nagpur. The Meenakshi Grish was the one who really helped on this trial. We randomized 50 depressed neonate to umbilical cord milking, and 51 depressed neonate were in control group and they received immediate cord clamping, and we use intact cord clamping in our intact cord milking in our study. So we did not see any difference in Apgar score or the delivery room resuscitation effort in the two groups. So the conclusion was umbilical cord milking was feasible and safe in a depressed neonate. Another study was published after our study. This study is from Bangalore, and this was done in a preterm baby. They randomized 30 preterm baby who were depressed at birth to cord milking group, and they use cut umbilical cord milking, and the 30 infant in a control group who were depressed at birth but received immediate cord clamping. They also didn't see any difference in Apgar score, CRIP score, or resuscitation effort in the two groups. There was significant increase in hemoglobin and serum ferritin at 6 weeks in a baby who received cord milking. And this indicates that cord umbilical cord milking can be efficient in placental transfusion. There are some ongoing trials on umbilical cord milking in depressed infant, and the first study is a ANUP study. This is a cluster randomized control trial with a crossover. He's planning to enroll 1,200 non-vigorous term babies, and he's comparing umbilical cord milking with immediate cord clamping, and his outcomes are NICU admission and neurodevelopmental assessment at 2 years of age. I think he has enrolled more than half of the babies for this trial, and it looks like probably umbilical cord milking is safe because the DSMB has not stopped this clinical trial, and I am really excited to see the results of this trial. The second one is Dr. Manoj at Jubilee Mission Medical College. He's doing a trial on umbilical cord milking using a cut umbilical cord. His control is immediate cord clamping. He's planning to enroll 400 depressed babies at term, and his outcome is incidence and severity of HIE. I think he is also completing his trial, and we are excited to see the results from this trial. And this is the study we are planning, cluster crossover randomized clinical trial on short and long-term outcomes of umbilical cord milking in neonates who are depressed at birth. Our PICO question is the infant equal to and more than 35 weeks of gestation who are depressed at birth compared to umbilical cord milking with immediate cord clamping. Is there any change in the survival without neurodevelopmental impairment at 2 years of age? This will be a cluster crossover randomized clinical trial in 7 centers in India. The centers will be randomized to either umbilical cord milking or immediate cord clamping, and then we'll do a crossover after 6 months. We are expecting more than 65,000 deliveries, 4,000 depressed babies, and 1,000 babies with moderate to severe HIE. And we'll follow this baby at 1 and 2 years for neurodevelopmental outcome. And we are expecting, we are hopeful that umbilical cord milking will improve survival without neurodevelopmental impairment in infant with moderate to severe HIE and reduce incidence of moderate to severe HIE. The second option for placental transfusion in a babies who are depressed at birth is ventilation with intact cord. And all the Helping Baby Breathe recommend, if possible, ventilate baby with intact cord and delay cord clamping for 1 to 3 minutes in depressed infant. These are some animal data. The early cord clamping before the onset of ventilation had large changes in heart rate, cardiac output, arterial and cerebral oxygenation during transition, and ventilation before cord clamping had a smoother transition with smaller changes on those vitals. This is an observational study which showed in infant without respiration before cord clamping increases the risk of death or NICU admission. And the risk of death and NICU admission decreased by 20% for every 10 seconds delayed cord clamping after breathing. These are some of the studies published on ventilation with intact cord. The first one is a Wentworth study. This is a single-arm study on 29 premature baby born between 24 and 31 weeks. And they provided ventilation with a CPAP or positive pressure ventilation with an intact cord, and they did a cord clamping after 90 seconds. And this study show ventilation with intact cord is feasible, but is challenging. Anup has two studies on ventilation with intact cord. The first one is on premature baby, and the second one is on full-term baby. And he didn't see any significant difference in clinical outcome, but he also didn't see any safety problem. The Dooley et al., they have largest number of babies with ventilation with intact cord. They had 276 babies born between 23 and 31 weeks of gestation. And their control group was immediate cord clamping, and their intervention group was resuscitation if needed and cord clamping at 2 minutes. They didn't see any difference in clinical outcome, but there was a trend for lower mortality with ventilation with intact cord. And recently they published the follow-up data or outcomes at 2 years of age. And in this, in their cohort, the risk of death or adverse neurodevelopmental outcome was better with ventilation with intact cord. This is another study which was published more recently on intact cord resuscitation versus early cord clamping in a depressed baby. And they were looking at the outcomes in the first 10 minutes after birth. This was a randomized clinical trial in Nepal, and they randomized 93 babies for early cord clamping and 63 babies for ventilation with intact cord. They saw better oxygen saturation at 1, 5, and 10 minutes, better heart rate at 1, 5, and 10 minutes, and better Aghai scores at 1, 5, and 10 minutes with ventilation with intact cord clamping. They also reported shorter time for cry or shorter time for regular breathing with intact cord clamping. We don't have much data on the outcome outside the delivery or the long outcome. So we have to wait for those data. These are some ongoing or planned trial on ventilation with intact cord. Some of these trials are going to answer on long-term safety and efficacy of ventilation with intact cord. Most of these trials are in premature baby. This one is in full-term baby. And this trial is an interesting trial. They're comparing a baby with cord milking and ventilation with intact cord. So we all are excited to follow the results on those clinical trials. But ventilation with intact cord is really challenging. There are limited space for staff. I don't know how it is done in India now, but when we go for resuscitation of a baby who is depressed at birth, there are at least 4 or 5 people from the neonatology team. There is one respiratory therapist, one nurse, 1 or 2 medical providers. So there are so many people. It's so challenging for a space to resuscitate the baby with the intact cord. Then there is also a problem with the length of the cord. Some deliveries, the length of cord is not enough for resuscitation of this baby. Another challenge is maintaining a sterile feed and providing adequate temperature, especially in a premature baby. So this might be a solution, the purpose-built resuscitation table. I'm sure this is going to be expensive, but this is also going to take a lot of space, and I don't know how technically this will be possible, but we are excited to look forward for the results from their studies. So I'm going to complete my talk here with some take-home messages. Delayed cord clamping saves life. It decreases mortality by 32% in premature baby. So delayed cord clamping has the same effect in decreasing mortality as antenatal steroid, and may be better in decreasing mortality by giving a surfactant to the baby. Delayed cord clamping improves iron stores and prevent iron deficiency during the critical period of brain development. Delayed cord clamping improves neurodevelopmental outcome. Umbilical cord milking can be an alternative to delayed cord clamping, but it is not currently recommended as a standard of care or routine practice. We still need to do this in a research setting. And we know the umbilical cord milking increases risk of severe IVH in extremely premature babies less than 28 weeks on gestation. So for infants who are depressed at birth, current recommendation from the most of the organization is immediate cord clamping. But the Helping Baby Breathe recommend consider ventilation with intact cord. The ventilation with intact cord and umbilical cord milking can potentially improve outcomes in neonates who are depressed at birth, but we need more study for safety and for efficacy of placental transfusion in this subgroup of babies who are depressed at birth. So we should continue delayed cord clamping till God or the nature goes high tech and starts delivering cordless babies. Thank you very much, and I can take some questions.
Thanks a lot, Professor Zubair. It was a great presentation, and yes, it has brought in the main, like, you mentioned a lot of studies you have mentioned and your experiences you have shared regarding umbilical cord milking, which is being great way and very safe way. Like I can add on by being the editor of one of Neonatology Journal of India, and there is a one paper which is going to be published. They have done a very small study and they've done a intermediate thing. What they've done is they've taken a long cord and they have put it hang it at while resuscitation in the trolley. They hang it on the top of the like vertically. So by gravity, the blood, and in that they have shown that more than 80% the blood baby receives is almost 80% of what it receives in delayed cord clamping. So and there were a lot of issues like especially in preterm which has been debated, but we still need a lot of studies. But that is a great way of doing favor to the babies who are depressed at birth, especially babies more than 28 weeks. There are questions, Dr. Amit, if you want to just kind of start with the question and answers box from
Yep.
Dr.
So, sir, the first question from Livert Memani Floors is, what are the contraindications to delayed cord clamping?
Yeah, so there is no real absolute contraindication, but there are some relative contraindication. One of them is when there are babies who are twins, monozygous twins, where there is a risk for the transfusion of the blood from the other sibling. So in the first baby, maybe we cannot do a delayed cord clamping. But the second baby, we should do a delayed cord clamping. sometime when there is a abruption of placenta or there is a cut in the placenta, this indication for not doing a delayed cord clamping in a baby. I
Okay.
know some people they are concerned. I know some people they are concerned about polycythemia in a baby who are SGA or who are infant of diabetic mother, but we should be doing a delayed cord clamping on those babies.
Obstetricians are also a bit wary about doing delayed cord clamping in Rh negative mothers and HIV mothers. So, is there any weightage in this concern or not? Because same blood is there.
I don't think there is a good data that they are contraindicated in a baby who have Rh incompatibility or who have the HIV.
Okay, thank you. So the next question by Dr. Muhammad Bahari is, if you do immediate cord clamping, you stop the only source of oxygenated blood to the baby, which is placenta. If you are not planning to do bag and mask while the cord is still attached, isn't better to delayed cord clamp for 30 seconds and then clamp to give oxygenated blood while resuscitation efforts are underway?
Yeah, that's a really a good question, because if you're doing immediate cord clamping, you are decreasing the blood to the baby. We should stimulate those babies and in 30 seconds, and we should do delayed cord clamping probably for 30 seconds or so. But looking at all the recommendation from all the organizations, they all say do a immediate cord clamping, but you can plan to do a bag and mask ventilation or stimulation with intake cord. Maybe that's another good area of research, to wait for 30 seconds on those babies and look at the short and long-term outcomes.
Till you do initial steps of resuscitation and observation, can be clamping could be delayed and then immediately go on for positive pressure ventilation after clamping the cord. Maybe that could be 30 seconds.
Yeah, again, we need to do a study on that.
Yep.
We cannot change our practice.
Yep.
Just because a lot of things make sense, but we need to really get evidence to change our practice.
Okay, and
but that's a good point. I think 30 seconds of delaying may or may not. One of the Anup study on a premature baby, many of those premature baby, they start breathing within 30, 40 seconds. So even if you don't do a bag and mask ventilation, you stimulate the baby, many of those baby, they start breathing.
Yep. And Dr. Levert again is here, and she's asking that the milking procedure, due to rapid administration of blood volume and pressure, does not produce consequences in the neonate. More if it is premature. Example, intraventricular hemorrhage. You have amply answered this question though.
Yeah, we don't have much data on the full term. Whatever you had done a lot of study on umbilical cord milking in full term baby, and you didn't see any consequences in a full term baby with this. But again, we need more study. I think the Anup study, what he's doing right now, is going to answer many of those questions.
And so, what length of Dr. Abdul Manan wants to know, what length of cord would you suggest to milk, because it's quite long?
Yeah, so if you're doing an intact cord clamping, it's about 20 to 25 centimeters of cord. But if you're doing a cut cord clamping, the study we showed equivalence with a cut cord clamping and the intact cord clamping, they use 30 centimeter segment. So I think if you're doing so if you're doing a cut cord clamping, probably you need to milk longer cord. But if you're doing an intact cord clamping, probably 20, 25 centimeters.
We also use 25 to 30 centimeters in all our studies. Does umbilical cord milking cause volume overload when baby is not crying?
Yeah, so that's really a concern because that can cause volume overload. Because what happens after birth, if the baby is not crying, the lung is not open. But with not crying means the baby is not breathing. If
Not
the
breathing.
baby is not breathing, then the lungs are not open. So blood is not really pulled uh, to the lung. So if you're giving extra blood with milking, that may cause uh, increase or volume overload, but can that also milking can also stimulate the respiration. But that's why there is a concern in a babies who are premature, because the premature baby, they have more problem with the cerebral autoregulation compared to the full-term baby. So if you give a low volume in a full-term baby, probably they can tolerate better because they have better cerebral autoregulation than extremely premature babies.
Okay, excellent. So Mohammed Amir wants to know that babies born to anemic mothers are more likely to develop anemia. If anemic mothers are given total infusion of iron in third trimester, the baby born to these mothers are less likely to develop anemia. A study from India and one from South Africa. Please enlighten with your opinion. So about intravenous iron infusion to mother in third trimester.
Yeah, so that's a good point in reducing the iron deficiency in mother and iron deficiency in baby, but just not the iron. Even if they have enough iron at birth, uh, that iron is good enough only for the 2 to 3 months in a term baby and probably 1 month for the premature baby. So they need iron um, after 1 month or 2 months. By doing a delayed cord clamping, we are increasing that storage of the iron. Um, so yes, giving a IV iron to the mother is a good idea. It prevent at least the iron deficiency during a very critical period of brain development, because most of the brain development occurs even before the baby is born. So even before the delayed cord clamping. So if we can prevent that iron deficiency by giving IV iron to the mother, that may improve brain development and long-term neurodevelopmental outcome. So even if the mother gets IV iron, we still need to do a delayed cord clamping in a baby.
Dr.
So that
Mohit,
was a good question.
Yeah.
the next question.
Yeah. So this is by some anonymous uh, participant. Does the obstructed like I think everybody is scared of obstetrician. That's why they're not writing the name. Does the obstetric team document whether they did delayed cord clamping in your hospitals?
Yeah, they do. So every baby, we have a documentation of delayed cord clamping. That's a note by the nurses. And when our team is there, the neonatology team, that definitely we document. But yes, the delayed cord clamping is documented in our EMR on every baby. And this is one of the QI project. This is one of our the QI benchmark, how many babies are getting a delayed cord clamping, because you've seen from the previous studies, a lot of premature baby, they're not getting a delayed cord clamping even in USA. So documenting is important. The first one is when you're documenting, you know how many babies are getting this. But the second thing, when you're documenting, then most of the people will do it because they're not going to document they didn't do a delayed cord clamping. So that's going to reinforce doing a delayed cord clamping.
So thank you, Dr. Zubair, for this, because this would be great for countries like India. Like your presentation showed that in China, only 30% of the babies born they have been delayed cord clamping, like those who are admitted to the hospital. In India, if I would take, it will be less than 10% even. So this
Yeah,
is
I
one
talked to
thing.
some of the pediatrician and some of the neonatologists in India. I don't think at many places, even in the teaching institution, delayed cord clamping is reinforced or is a standard of care. I think we have to change. And I compare this with a surfactant treatment because I know everybody wants to jump on the surfactant treatment because it looks fancy and this, but it's so expensive. And you have easier way or cheaper way of decreasing mortality than surfactant.
Yeah, now the thing is like for your fellows, you have to stop them for giving surfactant. instead. Like they will be all ready to give surfactant, but if you don't want, it's the senior person has to, tell no, this is, you should not wait. So you
Yeah,
are right.
we have reduced our surfactant use so much in our NICU or all over the USA because of the non-invasive
Yeah.
ventilation. Even 23, 24 weeker, if they are on CPAP, and if they are not requiring a more than 40, 50% of oxygen, we don't intubate those babies, we don't give them surfactant. The studies have shown not giving surfactant, managing on CPAP is better than intubating surfactant and keeping them on ventilator. So yes, you should avoid giving us surfactant is really a magic drug, but it has its own limitation. Surfactant is really good for the babies who are 32, 33, 34 weeks because their main problem is a surfactant deficiency. The 23, 24 weeker, they have surfactant deficiency, but their main problem is the lung development. So their lung is not developed. It's going to take some time. Uh, to me, the 32, 33, 34 weeker, they benefit more with the surfactant than 23, 24 weeker.
Yeah, very right. So Dr. Parthasarthi, he is asking, so do you suggest umbilical cord milking instead of delayed cord clamping for all babies of 30 weeks gestation or more? If so, are there any standardized method of doing the umbilical cord milking?
Yeah, so the first thing is I'm not recommending because we don't have study and none of the organization have recommended umbilical cord milking in any baby, depressed baby, not depressed baby. So we should do umbilical cord milking only in a research setting to generate more data. And once we have enough data, then we can look at a short and long-term outcome. And then the organization can make a decision to change the practice. So unless the guidelines comes from the organization about changing practice, I won't recommend umbilical cord milking. And again, there is a standard procedure for milking. You milk 3 or 4 times using um, with the entire cord clamping. You refill and then you milk 3, 4 times. There are many videos on how to do umbilical cord milking.
And in continuation, he is being asking in delayed cord clamping, is there any use of continuing delayed cord clamping after delivery of placenta?
Yeah, so that's a difficult question. As I said, most of the blood is transferred between 1 to 3 minutes. Some people, they do a delayed cord clamping till the umbilical cord stop pulsating or till the placenta is pale. But I don't think we should be continuing it after the placenta is delivered. There's some data on a prolonged for more than 3 minutes, and probably they have a better transfusion. But after the placenta is separated, I don't think there is any reason to continue uh, the delayed cord clamping.
So in continuation, like his question is again, will delayed cord clamping or umbilical cord milking interfere with collection of blood for cord blood banking?
That's really a very important question. And yes, the delayed cord clamp, especially in a premature baby, they're not much blood. So it affects the collection of blood for the banking. But the banking of this blood is probably not much useful, especially if you're planning to use it by yourself. And there is a recommendation not to use this uh, blood bank for your own blood. You can use it for donating to other people, but it's not useful for use of your own. There is a problem with the storage, and you don't know whether you're going to use it or not. So we don't encourage the blood banking of this umbilical cord blood. But yes, it will affect because there won't be much blood. Instead of banking this blood in the bank, why not just give it at the same time after they are born? And
So many commercial units, they are doing this umbilical cord banking. And so delayed cord clamping has to be abandoned in such babies, because they say that the volume left after we wait for 30 seconds is quite less. And so they have already been convinced by the obstetrician, or obstetrician has been convinced by the parents that they want to do this banking. And so then the obstetricians, they refuse delayed cord clamping, or the company person says, sir, we can't do delayed cord clamping because of this. This is a problem which I have encountered at times.
Yeah, I think this is because of the commercialization of this banking, and as I said, they are not really useful for themselves. It can be useful
Nobody knows what's
for
the
other
use
people.
are.
Yeah, yeah. And we don't know how the cord blood is going to be when we need it.
Whether the company will be there 20 years later when we need it, that's also
Yeah,
not known.
yeah, yeah. I think if the full-term baby may or may not, but in a premature baby, we should really try to convince the parent that there's so much benefit with delayed cord clamping in premature baby. They should do a delayed cord clamping.
Yes. You have already answered this next question about monochorionic gestation twins, that it's a relative contraindication. So we can move on to less. Please comment on hematocrit of these neonates under study. Mini Rani Akhori has asked, which study? Dr. Mohit, can you make out what Dr. Manjusha K, what does she plan to ask?
Hematocrit of these nutrients under study. I don't know if Dr. Manjusha wanted to ask the study like they have undertaken for cord milking. Maybe, I don't know. That is the thing Dr. Manjusha wants to ask.
Yeah, so yes, the cord milking or delayed cord clamping increase hemoglobin hematocrit, but I have shown and people have shown it does not increase the risk for symptomatic polycythemia. Just a polycythemia really does not mean much, and we don't have to do much for the polycythemia if the crit is less than 75 and the baby is not symptomatic.
Okay. Dr. Prashant Gowda wants to know, what is the scientific basis for mechanical ventilation with an intact cord? Though you have already explained it, but if you could say, add a few words on this.
Yeah, so when you do a ventilation, you're trying to open the lung. When you open the lung, the more blood is going to flow to the lung, and that's going to decrease the volume overload in the systemic circulation. And also, once you open the lung, that's going to improve the left ventricular preload, because the more blood is going to the lung, so the more blood is going to come to the left side of the lung, and that will improve the left ventricular preload.
Okay, that's great. And Dr. Prakash wants to know recommendations for delayed cord clamping in single versus multiple preterm gestation.
Yeah, again, the single and multiple gestation, if they are not monozygotic and there is no risk for twin-to-twin transfusion, then we should do a delayed cord clamping on all multiple gestation. But if they are monozygotic and there is a risk for twin-to-twin transfusion, then we should avoid first twin.
Okay, and Dr. Prashant Gowda continues his question over ventilating with intact cord is, how long do we ventilate with intact cord?
So the ventilation is for the baby. If the baby is not breathing, then you should keep ventilating. Is a delayed cord clamping is 1 to 3 minutes. So you should stop. We should cut the cord after 1 to 3 minutes. But you should continue ventilation. The ventilation is the baby is not breathing. So as long as they are not breathing, we should continue to ventilate those babies.
Okay, that's great. Dr. Rohit Shashidharan wants to ask you, why can't we go for physiological cord clamping instead of delayed cord clamping, where we can wait till placental separation, as what is seen in nature in animals. When we do an umbilical cord milking, it's not physiological. There may be increase in blood volume, but how will it ensure oxygenation, especially once the cord is cut?
So we are not recommending umbilical cord milking
Yeah.
for, or we are not. We are doing a study in a depressed baby where delayed cord clamping is not feasible. Um, I don't think there is a good data for physiological comparing a delayed cord clamping for 1 to 3 minutes versus a physiological when the cord when the placenta is separated. Um, I don't see any short and long term benefit for that because most of the blood is transferred within 1 to 3 minutes after birth.
There would be practical issues as well, waiting for the baby while the placenta separates and just waiting for more long time.
Yeah.
Good morning, everyone from Mexico. So Dr. Emilio is joining from Mexico and wants to ask. He says, "Congratulations to you, sir. It was an extraordinary presentation, which we all agree with. Clear and very dynamic. Yes, indeed. Why would it not be recommended to milk the umbilical cord in term infants? Though you have repeated it often, if you could do it
Yeah,
again."
thank you very much for the compliments. And again, I'm going to say, yes, we are doing a study on umbilical cord milking in a term baby who are depressed at birth. Once we should wait for milking all those baby till we get the results from this clinical trial. Again, there are two concerns. One is safety because we are milking the cord, so we are increasing the probably a cerebral uh, blood flow. We don't know the impact of that in a baby who are depressed at birth. The second thing is we need to see a long-term benefit of this umbilical cord milking. So all those can be answered with a clinical trial. So we should wait for the results of the clinical trial before doing umbilical cord milking in all babies using this as a standard of care.
Okay, and sir, Dr. Lala wants to know, do you know the reason or mechanism for increase in severe IVH in extreme preterm babies? Is it fluid overload or cerebral autoregulation dysfunction?
That's really a good question because I think Anup, he has looked into it, why those babies were uh, had a severe intraventricular hemorrhage. So if we look into the first one is definitely the poor circulation and because of the impaired autoregulation in those tiny babies, uh, the more blood is going into the brain and going into the germinal matrix and causing bleeding. But the few other things Anup has looked into it. And when he looked into his data, there was a more severe ventricular hemorrhage in a babies who were born vaginally or the normal delivery versus the C-section. And you know, most of the baby who are born vaginally, they have a preterm labor. And most of the preterm labor is associated with chorea and neonitis. So when he looked into the data more carefully, a lot of those babies, they had a histological chorioamnionitis who has an intraventricular hemorrhage. Against the histological chorioamnionitis can impair cerebral autoregulation and can increase the risk for IVA.
And sir, there is a question which I received on WhatsApp by a dear friend, Dr. Kiran More from Qatar. He says that excellent talk, Professor Zubair, very comprehensive and covering this topic. With concerns from Helix trial and potential benefit of delayed cord clamping in depressed infant, do you think we should try to do RCT with two interventions for developing countries, DCC with erythropoietin or DCC with melatonin? So can we add these two drugs, melatonin and erythropoietin, in the jigsaw puzzle?
Yeah, that's a really a good question because, as I said, one intervention is not enough for HIE. Even with a therapeutic hypothermia, we still have 50% of our babies. They develop either die or they develop a moderate to severe HIE. So one intervention is not going to be enough. So if you're just doing a delayed cord clamping, that intervention may not be enough. We need to combine with some other intervention. But before we combine this, we need to see whether individually they are effective or not. So we should wait for the trial on the melatonin and erythropoietin, and then the delayed cord clamping or umbilical cord milking. If some of them are effective or has some effect, then we can combine more than one. But I think initially we should look at the individual therapeutic options, whether they really improve neurodevelopmental outcome in HIE or not. So that was a good question.
Yeah.
Because we need multiple intervention for this HIE, because looking at the etiology and pathophysiology, we can't treat this HIE with only one intervention.
Excellent, excellent. That's true. And Dr. Prashant Goda wants to know if there is any benefit of transferring the stem cells by delayed cord clamping or milking.
So that's what we are doing when you're doing a delayed cord clamping and milking. You are doing a stem cell transplant. As I said, somebody has mentioned the delayed cord clamping is a first natural umbilical cord transplant. There is a study from Atlanta where they gave these babies the same. In a babies they stored cord blood, and when this baby developed HIE, they used that cord blood and they separated the mononuclear cells and they gave it to the baby who developed HIE. And as I said earlier, the amount of blood they are giving for treatment of this HIE is similar to what they get it with delayed cord clamping or umbilical cord milking. So umbilical cord milking or delayed cord clamping is a stem cell transplant for those babies.
And so there are too many questions. I would ask Dr. Manoj, do we have more time? But till he tells us that, there is a question by Dr. Escobar Cruz that what would be the optimal position of newborn with respect to maternal pelvis during late clamping of umbilical cord?
Yeah, I think it's putting the baby on the belly or the chest is good for bonding. And I think that's what we should recommend. But instead of delaying cord clamping only for 30 or 60 seconds, probably we should do a more prolonged delayed cord clamping, maybe 2 minutes or so. I think there is a study which showed if you do 2 minutes of delayed cord clamping, if when you're putting the baby on stomach, that is the same as delayed cord clamping when you're keeping the baby below the placenta. So you just, I encourage to put the baby on stomach and or the abdomen and just do a delayed cord clamping for longer period of time.
Yep. And there are just two about any side effects on of delayed clamping or milking on in preterm babies on ROP and what was it asked on ROP?
Yeah, that's really an interesting question. And in fact, the umbilical cord milking and some of the delayed cord clamping data has shown that decreases the risk for the ROP in a baby, the delayed cord clamping and umbilical cord milking. Anup has some of this data, and what he is thinking is when we do, the oxygen saturation at 5 minutes, that's an important marker for the mortality and morbidity. By doing a delayed cord clamping or umbilical cord milking, you can improve the oxygen saturation at 5 minutes. By improving oxygen saturation at 5 minutes, probably you can decrease the risk for ROP and other morbidity in premature babies.
Okay, and any effect on ductal closure?
Yeah, I showed that too. Again, this is a volume. So whenever you're giving a more volume, that's going to affect your ductal closure. And the meta-analysis from a clinical trial comparing a delayed cord clamping and an umbilical cord milking with the immediate cord clamping has shown there was a trend towards more treatment for PDA, medical as well as surgical, in a baby who received delayed cord clamping and who received umbilical cord milking. But again, the management of PDA is so subjective now. Um, we try to ignore PDA nowadays. We don't treat them unless the baby is really, really on ventilator. But the data was done even before we change our practice of treatment of PDA. So yes, it may affect physiologically because if there is a more volume, the duct is more likely to be open.
And how can COVID be left out in any discussion? So, is your practice of delayed cord clamping different in COVID positive mothers as compared to COVID negative ones?
Yeah, that's a really a good question. So when the COVID came initially, we stopped doing a delayed cord clamping on those babies. Then later on, we saw it's really the vertical transmission of COVID is so rare, and the benefit of a delayed cord clamping, even the breast milking, breastfeeding. Initially, we stopped breastfeeding, but now the practice has changed. So in a COVID baby nowadays, we are doing a delayed cord clamping. We are trying not to put the baby on the belly when we are doing a delayed cord clamping. We're just holding near the pelvis. So the baby is not getting in directly contact with the mother with the skin to skin care. But we are doing a delayed cord clamping in a baby who are mother who are COVID positive. That's an excellent question. And it changed so much in the last 6 months, starting
Yeah,
from not,
COVID is a ever-changing scenario.
yeah.
And can you, Dr. Kishore Sangvi, a very senior pediatrician neonatologist, he wants to know if, can you please define umbilical cord milking? You have already done so. How many times, over how much length, and how over how much time?
Yeah, so I think I defined it. So it's about 20 to 30 centimeters of segment. You do 2 to 5 times. Some people, they do 3 or 4. I think the 4 is probably the optimal time. And most of the time it takes less than 20 seconds. So you can do it in less than 20 seconds.
Okay. And Dr. Claudia Rota wants to know if in depressed term babies, umbilical cord milking increases cerebral blood flow. In your opinion, this means a blood overload if the pulmonary circulation is in fetal circulation. Does it increase risk of cerebral reperfusion? So does umbilical cord milking increase the risk of cerebral reperfusion? Can you suggest the resuscitation with intact fetal circulation as a standard of care for term babies nowadays?
So the second question, those are excellent questions. So coming to the second question first, the ventilation with intact cord. So if you're following the Helping Baby Breathe guidelines, they do recommend delaying the cord clamping and do a ventilation with the intact cord. So if you are doing it, that is recommended by Helping Baby Breathe. Coming back to the umbilical cord milking, yes, it can affect cerebral blood flow, but full-term baby, they have better cerebral autoregulation, and full-term baby, they don't have germinal matrix, so the risk of intraventricular hemorrhage is much more. Regarding the reperfusion injury, I don't have any data. I think we need to do more study whether umbilical cord milking is going to cause a reperfusion injury. Again, it's very hard to look at the reperfusion injury real time. Probably the long-term neurodevelopmental outcome is going to show you if there was a reperfusion injury with umbilical cord milking.
There is
Dr. Amit,
Hi, yes, sir.
there is sorry. In between, there were few questions. Like I don't know, if Dr. Rutul, he's asking like, what is your idea or take for delayed cord coupling in babies with antenatal abnormal umbilical artery Dopplers, like reverse or absent Doppler flow? So, what are your take regarding?
So that's a good question. When the baby they have abnormal Doppler, probably they have uteroplacental insufficiency. Many of those baby may be polycythemic. but we still do delayed cord clamping on those baby. If the blood is not flowing, that's a different story, but we try to do a delayed cord clamping on those babies too.
And similarly, somebody is asking, Dr. Pradeep Sharma is asking, in severe IUGR, is it recommended delayed cord clamping is to be done?
Yeah, it is recommended in all baby, even if they are severe IUGR. I know they can be a polycythemic, but I think there was a study recently published, I think last year or so, where they looked into the data on delayed cord clamping in a babies who were SGR, IUGR, and it is safe in those babies.
Dr. Amit, please continue.
So we are just going for the last question. And because it has been a very long time for sir to continuously speak for almost 90 minutes now. So oxytocin timing, oxytocin is often given to mothers soon after delivery of the baby. And so have you changed the oxytocin timing till the clamping has been delayed? Because it may be transferred to the baby through clamping. So the Dr. Rohit Shashidharan wants to know about oxytocin timing after delayed cord clamping.
Yeah, we do a delayed cord clamping for about a minute or so. I don't think they are infusing oxytocin during that time, but I need to discuss with my OBGYN what they are doing. I don't think they change any practice, but I don't have an answer for that. That's an interesting question.
Okay.
Yeah, so in one of the talks I've just heard, like especially in India, the centers, what they were practicing delayed cord clamping, they intentionally inform the anesthetist not to give oxytocin till the cord is being clamped. So till they delayed cord clamping, they don't infuse oxytocin to the mother. Like this is what they discussed, and the same question was asked there in few of the centers who were practicing delayed cord clamping in India. So they were telling anesthetists not to give oxytocin.
Okay.
But even I don't have the idea much.
So can we wind up now, Dr. Mohit?
I think so. We should. It's really tiring for Professor Zubair. I
Oh
think
yes,
so.
there are many more
No.
questions.
Yeah, yeah. If you want, you can send my email if people have questions.
Yes.
Send me
We
an
will
email
circulate
and,
that, sir.
yeah, they
So-
can answer question. Yeah, this
So-
was a great audience. They had really a great questions, and I'm happy that we had so much discussion after the talk. And thank you everybody again, and Amit, Mohit, and Manoj for giving me this opportunity. And NF, it was fun. It was great.
Over to you, Dr. Manoj.
Well, thank you so much, Professor Zubair. As usual, it's a pleasure listening to you. We wanted your session in last year itself, but somehow it did not work out. Now we are running on the neonatal hemodynamic sessions from this one onwards. Now we are having except the session in the last week of February, next few sessions are going to be on neonatal hemodynamics. So thank you so much for joining us. It's a great pleasure for us, and then we hope you continue to be with us and join us for the physical meeting IAP Neocon, which is scheduled in September also. And I should also thank the excellent moderation by the two legends in neonatal hemodynamics from India, Dr. Mohit Saini and Dr. Amit Upadhyay. Thank you so much.
Thank you.
And
Yeah, I totally agree with you. I think they did a extraordinary job moderating this session. Congratulations, Amit and Mohit.
excellent. And before we close, let me thank all of you, the dear delegates, because it was a marvelous to have the representation from so many countries, and then we continue to receive YouTube viewership in the next 24 hours because of the time zone match. Some of the delegates watch later, but it's a honor to have you all with us for this series. And talking of time zones, The next in the neonatal hemodynamic series is on a different timing. We used to have at 7:30 p.m. Indian time, but next one, because the faculty Professor Coeur Wall is from Australia to suit his timing, so we are going to have the next session alone at 4:30 p.m. on Thursday, 11th February. I cordially invite all of you to join us for this as well, and continue to be with us for the hemodynamic series with Patrick McNamara and other legends in the series. So thank you so much. Have a good day. Have a good night. Until we see next time. Thank you.
Okay, Manoj, thank you very much.
Thank you,
Bye-bye.
sir. Thank you, sir. We will keep in
Thank you
touch.
very much.
Okay.
Thank you.